Guys, welcome everybody. We're switching to English. By the way, Rudolf has been with us so many times, you know, this is somewhat the fifth language in the country. You know, because we have an Italian part and the French, the Retro-Romantic. And yes, would you agree? Do we have a Swiss-German part, Michel? Yeah, we do, 2/3. And so basically on our meetings, we agreed to speak English. And our faculty and also our basic and translational science is primarily done in English. Correct, Francesco? So you've seen some of them earlier today. And with that, I would like to welcome Rudolf de Boer, Professor Dr. Rudolf. In Holland, you write your doctor in small letters. That's the way it is?
Yeah, we're very modest.
Yeah, exactly. And I had the pleasure to meet Rudolf through my activities of the Heart Failure Association at the time. We had known him before. He is a brilliant translational scientist, very active clinician, but also does a lot of basic research. And Rudolf has now been elected a year and a half ago, not elected, but started working as the head of the Department of Cardiology at the Thorax Center, also leading cardiology and basically the rest of the thorax, right? And so that's what Rudolf did. That was formerly Martin Simon's position, etc., and others, and Patrick Soroy's was never head there, but worked there for many years. It felt like that he was the head there, but Rudolf is directing that, really hands down one of the most famous heart centers we have on the continent, and I think that is fair. And he is the perfect candidate to not only get it into new heights, but he is very well known all over Europe and on the other side of the Atlantic for all his research, not only in heart failure, but cardio-oncology and basic science and translation, whatever we have. So Rudolf, what are you going to talk about?
Cardio-oncology. Well, thank you very much for the invitation. Very kind introduction, for pure flattery, so it almost makes me blush. So without further ado, I'll get started. Talking about the relationship between heart failure and cancer. And so here's some of my disclosures, none having to do with cardio-oncology though. And I chose as a title, the reciprocal relationship between heart failure and cancer. In modern medicine, obviously, we tend to split up medicine in internal medicine, nephrology, cardiology, oncology. But in reality, I think many of the patients that we care for are the same. So it's time that oncologists and cardiologists get together. Well, this is what most people think about when they think about the relationship between cancer and heart failure. It's classical cardio-oncology. We know that patients with cancer are prone to develop cardiovascular disease, specifically heart failure, because of antineoplastic treatments, for example, anthracyclines or radiotherapy, but also because of direct effects. We know that patients with advanced cancer suffer from cancer cachexia that's associated with a very disadvantageous internal milieu with effects on the cardiac muscle. For example, cardiac atrophy is observed in advanced cancer. Well, the ESC has put out the first cardio-oncology guidelines about 1.5 years ago. I think it really helps to advance the field. These are 267 recommendations. 7 of those are class 1A, and all the other ones is opinion-based. So there's a bunch of people sitting together, let's say, spurting out opinions about cardio-oncology. That's what it is. This is a dynamic document. I think the next update should hopefully contain many more evidence-based recommendations. So since we're talking about cardio-oncologists, maybe briefly I can explain to you the cardio-oncology guideline in 1 minute. CTR-CVT is cancer therapy-related cardiovascular toxicity. It starts with taking a good risk assessment, either low risk, then the risk is usually increased during cardiotoxic cancer therapy, and then there is a long-term surveillance. And of course, if the risk is higher, then the incremental risk becomes higher, or even very much higher. So this is basically in a nutshell what it looks like. And based on this, one should construe a cardio-oncology strategy. Start with a primary and secondary prevention strategy. So take somebody's risk, act upon it or not, then do good surveillance during cancer treatment when the risk may actually increase. So be sure that it doesn't get out of hand. And then the period directly after the first year is very important. Do reassessment. And then, of course, there's cancer survivorship programs. So if you're lazy, you don't want to read the 63 pages of the ESC cardio-oncology guideline, you can just look at this slide and it's all in there. So that's cardio-oncology in a nutshell. So that part, I think, has been studied quite intensively. What we know far less about is how heart failure affects incident cancer. And that's what I want to zoom in today. So it started, I would say, about 8 years ago or so, with observations done in various registries. We're always envious on our Scandinavian colleagues. They have very good registries. This is an example from Denmark, where they matched control subjects to subjects with heart failure, about 9,000 patients with heart failure. And in each age stratum, so between 60 and 70 or 70 years and older, there was always excess incident cancer in those patients that had prevalent heart failure. Of course, this is a sheer association, but it has been backed up by many others. So I will show you few, but there's really 10 or 20 papers out there. This is a very large study from Italy by Eduardo Bettero, about 100,000 patients with heart failure matched with 100,000 control subjects. And the cancer-related mortality was much higher in patients with prevalent heart failure. Again, an association. But looking into more detail into associations can also tell you something about the likelihood of it being true. And if I look at this split up, I'm more inclined to believe it's true than just looking at the crude data. That is because the association is stronger in younger patients and is less outspoken in older patients. And this is generally an observation in predictive epidemiology. In the very elderly, it's hard to predict. There's so many things ongoing and the risk kind of dissipates. But if it's true in younger patients, it might be true. So another piece of information. This is an entirely different way of looking at it. These are about 5,000 patients that underwent stress echocardiography. We know stress echocardiography generally is used to map myocardial ischemia. And the striking thing here is in a follow-up of about 11 years, a positive stress echocardiogram was associated with an 18% increase in cardiovascular mortality, which makes sense. But it was also associated with a 19% increased risk for incident cancer, which doesn't make directly sense, but it's, again, supportive of the hypothesis that the presence of cardiovascular disease predisposes to incident cancer. So, well, there's many more, but altogether, there's also a recent meta-analysis. Prevalent heart failure appears to predispose to incident cancer. Next question, of course, is since heart failure is a lethal condition, you may also argue, is it important then to look out for cancer because patients with heart failure will likely die of heart failure anyways? But that's not true. This is data from Spain, looking for the mode of death in patients with heart failure. And as you will appreciate, about 20 years ago, a large proportion of patients with heart failure died of cardiovascular causes in blue. But over the course of time, the percentage of patients dying of non-cardiovascular causes in the heart failure cohort is actually increasing. In other words, patients die of other causes than cardiovascular causes, which, by the way, also has very important repercussions in trial design. But that's another issue. This is another way of looking at it. These are relatively recent randomized clinical trials. The I-PRESERVE and TOPCAT in heart failure with preserved ejection fraction, the Paradigm HF in heart failure with reduced ejection fraction. And if we zoom in on the proportion of patients that dies of non-cardiovascular causes, then cancer is always the leading cause. So we put a lot of efforts as cardiologists looking into pulmonary disease, renal disease, infectious diseases, but we rarely think of cancer. But that, in fact, is more important when you think about the mode of death than renal disease or infectious disease or pulmonary disease.
I will ask a question. Do they die with or because of it?
This is what the investigators filled out in the HFpEF as the cause of death. Of course, we don't know for sure. Somebody may have cancer, then dies of sepsis, and somebody ticks a box. Cancer.
When I ask oncologists and say, what do the cancer patients die of? Maybe you know better than tell me.
Yeah. Now,
in cachexia on palliative care, that's different. But some of them die suddenly and they don't really know in the European registries, but you know better. I'm just asking.
I'm getting at the very end of it. I think the adjudication of endpoints in cardiovascular trials is okay when it comes to cardiovascular causes, actually not very good. But if you look into non-cardiovascular causes, it's poor. Likewise, in the oncology field, oftentimes the HFpEF just says other, that's it. And then nobody cares anymore. So we should change this. But this is what people report with all the intrinsic limitations. Okay, so the observation, the quite, I would say, consistent observation that incident cancer is more prominent and more frequent in patients with prevalent heart failure, we refer to it as reverse cardio-oncology. So, of course, describing it is one thing, but the interesting part is to think about how this may be explained. So here's a list of factors that may be associated with this phenomenon, and I'll be showing some mostly preclinical data, shedding some light on these mechanisms that may actually connect heart failure and cancer. So first, shared risk factors: smoking, obesity, sedentary lifestyle, diet. We all know this is associated with increased cardiovascular risk, but in fact, many of them are also associated with risk of cancer. So what we did is we pooled data from the Framingham Heart Study with a community-based study in the Netherlands, the PREVENT study, altogether about 20,000 patients, waited for about 15 years, and then we calculated the atherosclerotic cardiovascular risk score. It's at the very bottom. So it's a very common, well-to-do risk score for cardiovascular risk. And then we divided the entire population in quintiles of cardiovascular risk. And with increasing cardiovascular risk, there's actually increasing risk of incident cancer. So if you calculate somebody's cardiovascular risk, you also calculate the risk of incident cancer. I think not many people realize this. Then, of course, a secondary question is, if you drive down cardiovascular risk, do you also drive down the risk of incident cancer? So this is a pooled analysis in A of antihypertensive drugs, and then on the left side of statin trials, and on the right side of SGLT2 inhibitors, trials done in patients with cardiovascular disease, but then with a specific focus on the presence of incident cancer. And as you can see across the board, there is no effect of these drugs, no beneficial effect on cancer. So this kind of negates the notion that it is a causal relationship. But I think what we should realize is that cardiovascular disease usually progresses faster than cancer. The lag time of between, let's say, tumorigenesis, so the initial DNA mutation, and let's say overt clinical cancer is about 10 to 20 years. And of course, these trials usually have a follow-up of about 1 to 5 years maximum. So I'm not really sure if this is a definitive answer, but as it stands now, we don't have any data to support the use of cardiovascular protective drugs to drive down incident cancer. So a second hypothesis is that with heart failure, which is a systemic condition, that there are circulating factors that communicate with distant organs. We know this is true, for example, for the kidney or vessels, but it may also be true for tumors. So for that, we did we used a laboratory setting, and we asked ourselves if heart failure associated circulating factors, if they may cause new onset cancer. So we subjected mice that carry a mutation, an APC minus mutation, that is also carried by some humans, and that give rise to intestinal polyps that are precancerous and usually progress towards cancer. So we subjected these mice to myocardial infarction to provoke heart failure. We waited for 6 weeks, and then the endpoint was not cardiovascular function, but was tumor growth. So first, of course, we phenotype the heart failure phenotype. We did mouse MRI. You see it's large epico anterior infarction, and in panel B you see there's low EF. There's fibrosis in panel C. So well, this is heart failure. I'm sure you all trust me on this one. It's quite severe heart failure. And then in panels A, B, and C, we counted the tumors, we measured the tumors, and we calculated the so-called tumor load. And you see in the sham-operated rats, there already is substantial tumor load, but in the mice with heart failure, there's much more. In other words, the presence of heart failure accelerates tumor growth. And there was also a clear association between the severity of heart failure, so the lower left ventricular ejection fraction was, the higher the number of tumors. So to kind of provide a second layer of evidence, we repeated the experiments because, of course, with heart failure, there's also hyperperfusion of organs. So one may argue that the hyperperfusion is responsible for the tumor growth. So we repeated the experiments. Again, we subjected mice to myocardial infarction, and after a week, we transplanted the failing heart of the mice into the cervical area, leaving the normal heart in place, but adding an additional failing heart that then would secrete factors or not. And then we again took out the gut and counted the tumor counts. So we transplanted a heart with a left ventricular ejection fraction of 27%, which clearly is below average. And again, so we also did sham operations, transplanting perfectly healthy hearts. But again, the presence of a failing heart, also when added to a healthy heart in situ, was associated with a higher tumor count, a higher tumor number, and a higher tumor load. So from the in vitro studies, we concluded that the presence of a failing heart is associated with tumor growth. In a separate part of this paper that I won't be showing today, we also did in vitro experiments, and we identified several circulating factors, amongst which was serpin A3, which is a protein associated with fibrogenesis, was strongly associated with both tumor growth and was also excreted by the failing heart. Well, ever since, and I think that is important, there was additional evidence was generated by independent laboratories throughout the globe. So, for example, MI-provoked heart failure was associated with breast cancer, with colorectal cancer, with lung metastases, so by other labs in New York, in Israel, on top of our data. So I think there's now pretty solid accumulation of evidence, and these are the papers in the slide that reported on these data. So that's then circulating factors. Well, then of course there may be other factors that are also part of the heart failure syndrome that may also explain the propensity towards tumor growth, and one of them is inflammation. So we know that the heart failure syndrome is associated with a low-key, slumbering, inflammatory state. There's a lot of review papers summarizing how this all may come about. Probably has to do with direct cardiac factors, but also with the affection of other organs that become diseased in the heart failure syndromes, and a large number of cytokines have been suggested to be the mediators of this inflammatory process. But then if true, and I think there is consensus that inflammation is a part of heart failure, then this may become also important for cancer growth, because we know that tumor-associated inflammation is also very important in the initial growth of tumors. So, and of course, for the tumor, it's not important where this inflammatory signal comes from. It may be local, but it may also come from another organ. Another way of looking at it is this trial, the CANTOS trial with the IL-1 monoclonal antibody canakinumab. It was originally designed to drive down coronary disease-related endpoints, and it was actually a positive trial, so though it was borderline positive. Oh, now it's doing it by itself. But in the secondary analysis, the interesting part was the very same molecule, canakinumab, also reduced the incidence of lung cancer. So here you have an anti-inflammatory compound that both reduces coronary events, but also incidence cancer. So it kind of suggestive evidence that inflammation is important for both. So we recently put out this paper. It's very experimental, but we used 3 different mouse models: a genetic cardiomyopathy model, a pressure overload model, MI model. We did a multi-omics approach with transcriptomics, proteomics, metabolomics, and then we looked in the biostat, which is a large heart failure cohort, a pan-European cohort, if these factors are elevated as they are in the mouse models. And indeed, several of these secreted factors, so by the heart secreted factors, could also be observed in increasing amount in the plasma of patients. So of course, what we don't know if this also gives rise to a higher likelihood of cancer, but at the very least, it corroborates the idea that the heart is an endocrine organ. So there's 2 more potential mechanisms that I would like to discuss that could also explain the intense interaction between heart failure and cancer. So first is clonal hematopoesis of indeterminate potential. I'm sure you heard about it. We will abbreviate it as CHIP. The CHIP is associated with adverse cancer and also cardiovascular outcomes. So over the course of lifetime, every one of us accumulates mutations in all kinds of cells, including hematopoietic cells. And over the course of time, these may then actually progress into malignant disease states. So it's been associated with hematological cancers like myelodysplastic syndromes, leukemia, and so forth. But quite frequently, it also has been associated with cardiovascular disease. Myocardial infarction, stroke, and also in heart failure patients been associated with worse outcomes. So somehow this has importance for both cancer and for cardiovascular outcomes. But this was in prevalent disease. What we then studied is if it was also associated with incidence heart failure. Again, making use of the PREVENT study, 8,592 healthy inhabitants. There were 374 cases of incident heart failure. And we age and sex matched those with controls, a case control design. And then we checked if the presence of CHIP mutations was associated with an increased likelihood of cardiovascular disease, as it does with cancer. This was the research question. So first, it's interesting to see that CHIP is rather infrequent in younger subjects. So below the age of 50 or so, it's uncommon. But if you get older and above 70, already about a third of all people have CHIP mutations in their DNA. Most of us have 1, very few have 2, and not many more genes tend to get mutated. And there's a few, let's say, pet genes that get mutated in this CHIP field. People who are working it will recognize the abbreviations. So in our hands, the presence of CHIP mutations were not associated with an increased likelihood for incident heart failure. There was not even a signal. So we were kind of surprised. So what we did is we checked for factors that were associated with the presence of CHIP. And as you will appreciate, by far the most important driver of CHIP mutations is age. And again, as I showed you, if you get old enough, it becomes difficult to study associations. Another quite interesting association with CHIP was anti-proBNP, but we know anti-proBNP also increases with age. So I think we're probably looking at the same. So then we divided the cohorts into the median of age, which was 65. And you see in younger patients below 65, there is an association between the presence of CHIP mutations and the incidence of heart failure. But in older ones, it's not. So I think it really has to do with age. Age is just a confounder of anything that you might consider studying, especially when age associated. So the final one I would like to discuss is the microbiome. This is a paper that we just published last week. The microbiome, of course, has attracted a lot of attention in many fields of medicine. We know that the presence of heart disease is associated with microbial dysbiosis because of gut congestion and secreted cardiac factors. But the other way around is also true. People who have a perturbed microbiome also have a higher likelihood of heart disease. And the same is true for cancer. We know that a perturbed microbiome may also accelerate tumor growth, whereas patients with, for example, colorectal polyps also have an abnormal microbiosis. So it's a very complex interplay, and we like to zoom in it. So what we did is, again, we turned to mice. We subjected them to 2 perturbations, MI and transverse aortic constriction. And then after 6 weeks, we collected stool samples, and we sequenced the stool samples for the microbiome composition. So the first result was quite interesting. Doing the principal component analysis, we were able to identify mice with heart failure looking at their microbiome. Quite frankly, it's a very complex way of looking at heart failure. I would do it differently, maybe do an echo. But if you run out of ammunition, you can always take stool samples and then look for the microbiome composition, and then you can pretty accurately guess if the mouse was suffering from heart failure or not. So mice with heart failure had a perturbed microbiome. Well, then zooming in on specific bacteria that were abnormal, well, you will appreciate that there are certain classes that were perturbed to a larger degree than other ones. Of course, we carry literally millions of bacteria in our gut, but certainly a few specific species were specifically affected. So then to prove causality, because this is an association, we repeated the experiments. We subjected mice to MI, waited for 6 weeks, took the stool samples, but then in a subsequent experiment, we injected mice with AOM and then with DSS. This is a very well-established model to provoke colorectal tumors. And then we transplanted the mice with feces, either from mice that suffered from heart failure or from mice not suffering from heart failure, normal mice. So then the hypothesis, of course, is that heart failure stool, so to speak, would provoke the tumor growth. Well, I didn't notice you can actually also do coloscopy in mice. That's on the right side. But you can also count the tumors if you take them out. And you see that mice that were transplanted with stool samples from mice suffering from heart failure had larger tumors, tumor count, or more tumors, sorry. And the tumor load overall was increased. And also visually, there's clearly more polyps there if the mice are transplanted with heart failure poop. So I think this provides a causal causality to the association between heart failure, cancer growth, and the microbiome being in between. Of course, next question is what to do now, but we published the paper and then we called it a day. So this is the graphical abstract. So what we did is we described the abnormal microbiome, we transplanted it. At the very end, this is also part of the paper, we also sequenced the stool that was transplanted, and it contained exactly those factors that we know of that can also provoke colorectal cancer. Final piece is also just published. I think it's kind of interesting. There's, of course, enormous interest into immune checkpoints because they may be inhibited by immune checkpoint inhibitors in cancer. It used to be second or third line therapies, but nowadays it's becoming first line therapy. Many people with advanced cancers nowadays can survive because of this great therapy. But we know that immune checkpoint inhibition is also associated with cardiovascular side effects, specifically myocarditis. So what we did here is we measured immune checkpoints in plasma of patients with heart failure, healthy, New York Heart Association class 2 and 3. As you can appreciate, there is a clear trend for a few of those immune checkpoints to be elevated in heart failure. Again, suggesting some form of crosstalk. It's actually, when we looked into biostat, it's also strongly associated with worse outcomes. So we're now zooming in on this more, but I think the checkpoint inhibitor therapies and the associated side effects really deserve study because it's becoming more and more important. So now I'm getting to what Frank was just asking. So where are we now? I think in the reverse cardio-oncology, the basic observations are pretty solid. And I think there's data accumulating that the presence of heart failure or cardiovascular disease at large is associated with tumor growth. Immune cell reprogramming is important, and there's other shared mechanisms, risk factors, metabolic abnormalities, CHIP, microbiome, inflammation, likely there's more. what we really need to start doing, and that was Frank was recording, is to record and adjudicate oncology endpoints in cardiovascular trials, and also record and adjudicate cardiovascular endpoints in oncology trials. That's something we don't do, and that's a gap in knowledge. For that, you need to form transdisciplinary research teams and transdisciplinary clinical teams. And I think these efforts may result in a set of deliverables, identification of disease-specific pathways. We don't know if heart failure-associated cancer is anything different from, let's say, regular cancer. I don't think so, but we need to study. Identification of disease-specific biomarkers. It would, of course, be extremely useful if we could inform ourselves and patients about the risk of cancer. To optimize cancer screening protocols for cardiovascular patients. Right now, for example, the colorectal surveillance program usually starts at a certain age, 50 or 55, but maybe patients with MI should be screened at the age of 45. I don't know. And also optimize cardiovascular screening protocols for cancer patients. These are summarized in the guidelines, but we need to optimize. So I think that's what we need. But that is all in the future or near future. So what to do now? I think it's important to at least think of cancer. Patients with advanced cardiovascular disease are at risk. It's a common and lethal comorbidity. I would advise actually my patients with heart failure to really adhere to the screening programs for colon carcinoma, breast carcinoma, and cervix carcinoma. I think it's important to realize that anemia, of course, is common in the setting of heart failure, but it's not always heart failure associated. It may also be an indication of cancer. So we should be cautious using IV iron, but we have no clear recommendations with regards to therapy. So these are the people that I work with, that did all the work. I'm also on this picture. And I like to, so I think this is also telling, this picture, probably easy to recognize Frank. And I'm also on this picture. On the right side at the end, we had a great time. This was in Vienna. So it's important to team up with large groups so that you learn of colleagues, have some fun every now and then, and get connected. So with that, I'd like to end. Thank you for your attention, and hopefully you have some questions.
Thank you, Rudolf. That was wonderful and thought-provoking. It's a lot of, it's our motto in the department. What we have some is get rid of the silos. This silo thinking that started here, that we all went, this is just EP, this is just the intervention, this is just heart failure, and we work together. But that's the same tools in all of internal medicine. If you only see the heart, you are not a good cardiologist. So, and we have to reach out to oncology. I have a lot of questions, but first it's yours. Please ask him questions, and that opens up new avenues of research as well. Tchaikovsky.
Thank you very much. Very interesting talk. Are there any certain types of cancers that are overrepresented, or are they the usual suspects in heart failure patients?
That's a good question. Again, we're somewhat limited by the preciseness by which the cancer was, let's say, identified. But a few ones consistently come up: lymphoma, urogenital cancer, renal cell carcinoma and bladder cancer, colorectal, and lung cancer. So breast cancer is difficult to study because there's fewer heart failure patients that are female, but there appears to be association too. But for example, prostate cancer, which is very common in heart failure patients, is not associated with heart failure. People explain that, but for example, because prostate cancer is encapsulated somewhat of a isolated disease, so to speak. So the more systemic forms, of course, are more, let's say, susceptible to signals from the outside. Lymphoma being the best example, which of course is a systemic disease. So yeah, the true answer is there's many more rare cancers that are not in such repositories that we don't know about. Yeah. Everybody honestly.
This is a very good question because, there was a couple of years ago, not a couple, it was 10 years ago. We published a Circ paper with our group on our transplant patients. We saw patients on statins had less skin cancer. This is, just our cohort. Circulation liked it, but it was just a start. We've seen that in a lot of transplant cohorts now. And then we had to discuss it because it was just an association. We couldn't show causality or whatever. But at the time, I remember that. I heard for the first time, someone said, oh, well, maybe it's not just the immunosuppressive drugs. This end-stage heart failure patients that you are transplanted are maybe at risk of higher of cancers. That a reviewer brought up. Ma'am, I don't know whether it was you back at the time, but that was one of these ideas. And there is actually a lot of similarities with it as well. And your questions goes to that because there was a trial, and I want to help you with that. You remember the Illuminate trial? That was a CATP inhibitor and statins. Isabella, you remember that? That had an unexpected increase of cardiovascular deaths, although LDL went down and HDL went up. And they looked at it, and I saw the data. They have never published it. The same happened with the cancer. So the cancer also went up with this HDL increasing drug, torcetrapin. The same as cardiovascular. So why? And then I asked them the question that you said, what cancers are there? And you know what they were? Lung cancers, colon cancers, and skin cancers. So we asked them, what would be the mechanism? And we said, could it be with our standard? A cancer cell has a carcinoma in situ, has a fibrotic kind of ring or protection, in a nutshell. And it becomes more invasive. So when cancer develops in 2 years, it's not de novo carcinogenesis, but a carcinoma in situ that was there before you started becomes more invasive. What's your thought on that? It's a long question, but we've seen that.
I agree, and that is also a disclaimer. I think I'm talking about cancer, but you're right. So this is tumor growth. It's not carcinogenesis, which is really the true initiation, and that has to do with toxic radiation and so forth. So, but it may very well be true, and this at least appears to be a trial where both endpoints have been reported. Another example, for example, being ARBs, but there was a disparate observation, and we should realize that if you're really successful in a drug in driving down cardiovascular-centered mortality, you get a paradoxical increase in cancer. So it's pretty difficult to really dissect out. But since these are systemic drugs, it's probably very naive to believe that none of them ever would have an effect on carcinoma in situ. They may have.
So our idea, I fully agree with that. We thought that a statin, we all assume the plaque gets harder, it's less unstable. Whether that's right or not, after 30 years, that's what we think and still don't understand. But we say a statin somewhat makes the formerly unstable plaque a little bit more stable. That's a little bit what we think, don't you? And the necrotic core, and it gets more stable, the plaque. So other people said that maybe whatever, I'm not assuming the statin is it, maybe the carcinoma in situ, which has also a fibrotic cap, gets weaker or more rigid, and the tumor becomes less invasive. That's what some people say. I'm not sure, but what would be important, as you say, that we in the cardiovascular trials look exactly what kind of cancers occur and are less likely to occur. Yeah. I'm not sure whether that is a way to look at it.
I absolutely believe so. And right now, for example, what you see, there's quite some labs and startup companies are interested in anti-fibrotic drugs, which come with certain risks. And I've seen in some programs, and I really like it, is that they have tested the drugs both in cardiovascular models, but also in cancer-associated fibroblasts, just to make sure that they don't mess up the stroma, provoke spread, etc. So I think slowly it's kind of sinking in that you can't really do the one without touching the other.
But that mineral corticoid receptor antagonists do have some antifibrotic capacity. Would they then increase cancer?
Yeah, well, in the trials they don't, and I think it's not a one-to-one phenomenon. And with many systemic drugs, side effects do come, but I'm actually surprised how few side effects they have. Thinking of that they end up everywhere in the organism. So usually I think we get away with it quite well.
Our gastroenterologists have, as you know, they showed that they have several papers, some of them in revision, presented some of the data already, where they show with the microbiome, they can basically diagnose cancer.
Yeah.
And that's it, and that's ongoing highly accurately, and modulating the microbiome to some extent will modify that risk. And same with heart failure too. As we've seen with myocarditis, we're
just joking this morning that most of us become cardiologists to stay away, anything below the diaphragm, and now we have to start doing microbiome anyway. So, do you have a question?
I just wonder about the phenotype of heart failure. Does it play any role? You showed association is HFpEF seems to be the same, but I mean, is it maybe like obese phenotype in HFpEF more, or are there any data on that?
It's a good one. In our hands and also other labs, the associations were stronger in post-MI models. I think there's more action there, right? More inflammatory component, and it's a very fierce model, so to speak. In human medicine, I'm not so sure. I think many patients suffering from HFpEF have a perfect milieu for cancer, obese, old. So we don't know, but likely it's also very important in HFpEF. And we know that the proportion of HFpEF patients dying of non-cardiovascular causes is way higher. So there must be a large proportion of cancer.
Maybe HFpEF is cancer when you look at the amyloid and you have a clonal whatever doing something. It's not only AL, but I think cardioimmunology is one of the ways of looking at it too. There's a lot of immunological activation. We preach that every time here in both diseases, and there's an overlap.
I have a question. Oh, okay, thank you. Very nice presentation. My question is the following. Are you aware of studies, or what's your take on the correlation between myocardial ischemia and the incidence and correlation with tumors? You showed in your studies that hemodynamics do not play a relevant role in your animal models, and it's the presence of a failing heart on an ischemic basis that drives this process. So the question is, should we screen our heart failure patients for incipient ischemia? Because we know that cardiomyocytes in failing heart are not healthy ones. They're pressed with a molecular milieu that drives the survival of these cells who are suffering, but maybe the same molecules are also have a detrimental effect on a systemic level. So whether you're aware of correlation between ischemia, which is a not very physiological milieu, and the correlation with the incidence of tumors.
Good question, sir. At the very beginning, I showed you a study from Italy in the stress echocardiography, which I think is almost synonymous to myocardial ischemia. And patients with a positive stress echocardiogram indeed develop more often cancer over time. So there appears to be an association. Then, of course, the next question is how to explain exactly. I think what your question also kind of reinforces is that's important in this whole plethora of observations and potential mechanisms is to kind of bring it back to something tangible of what we can do. And I also ended with, saying here, maybe we should think of refine existing screening programs and kind of prioritize patients with prevalent cardiovascular disease and maybe call them in 5 years earlier or so. This would be a very practical thing to sort out, and it would also pay off, in an effective measure that saves lives. So So then you bring it back to something more practical on it. In the hindsight, labs will, go around with mechanisms, etc., and hopefully we find, the one protein explaining everything, but we won't. Thank you.
There are two questions from the online audience. But quickly.
Very good.
So there is one question: cancer and cancer therapy, chemo or radio or both together, which one is better related with heart failure progression?
Yeah, so good question. And cancer therapy clearly is a simplification of many things. I think of most systemic therapies we know quite well nowadays of how cardiotoxic they are. And radiotherapy also has specific toxicities, both myocardial, but specifically vascular. It's associated with vascular events and also valvular disease. So a combination certainly is more toxic than chemotherapy alone.
Okay, and there's another question. Do you think that the heart failure related secretome can affect the cancer stem cells and lead to increase in cancer progression?
So I have to answer now, and I'm not an expert in cancer stem cells, so let me just say yes. I think it can. No, it's a good one. So again, I think it boils down to where in the process, the today discussed phenomena are important. Stem cells are sitting there waiting to get hurt, basically. Again, if the internal milieu becomes disturbed, as it does in heart failure, I would say likely, yes, they're also affected.
Rudolf, very, very brilliant talk. Thank you very much for sharing. You showed this nice correlation, your experimental data, inverse correlation between ejection fraction and number of tumors. So one possibility related to the comment from Marco is that oxygen consumption and extraction in peripheral organ could actually participate via anaerobic glycolysis and metabolic changes in cells. And this is true from the arterial side, but can also be true from the venous side, because congestion, especially in the splanchnic circle, could contribute. We know that congestion is a driver of inflammation. So from the arterial and venous side, we could have, both drivers of this lesion. What's your take on this mechanism?
Well, good thinking. I never thought about it, but you're right. The venous congestion component of many of the abdominal organs is more and more recognized to be important. And I can imagine that is not a particularly nice environment for early cancers, with accumulation of all kinds of factors that actually need to be transported rather than stick around. So very interesting and a new way of thinking about it. Might be true.
And I actually wonder whether venous congestion starts much earlier that our failure is diagnosed. Regardless from end-diastolic filling pressure, maybe congestion. I don't know. Also, Frank, maybe if you want to comment, but especially also in obesity, maybe it's something we don't know. We don't know yet when congestion starts. In the micro environment.
It's not only backward but also forward. Tumors are vascularized, even not on the back end to the venous, but there are tumors, there's endothelial dysfunction before, towards that. Tumors are highly vascularized. Whatever that plays a role, but so are plaques. In where there are the common ground, and there's an immunological activation. We know that this all the work we've done on rheumatoid arthritis. They have endothelial dysfunction way long before they have overt cardiovascular symptoms. That's with all the autoimmune disease. Oncology is the same thing. It's systemic diseases. Atherosclerosis is a systemic disease, as cancer is probably to some extent. Other question was, yeah.
Thanks for that very interesting talk. I have a question concerning prevention of cardiotoxicity. I was wondering if there are any new players coming up that can help us to prevent cardiotoxicity in our patients, because we have all this, we do a global longitudinal strain to see, early cardiotoxicity. We can have ACE and ARB inhibitors. I know that there are some studies going on exercise training, for example, in females undergoing treatment for breast cancer, and there were some data showing that they might have less impact on their heart and their overall life expectancy frequency. So what is
Yeah.
your thoughts on this?
Now, very important question. So in the cardio-oncology guidelines, there is, I would say, almost a third of the content is devoted to this specific issue, hunting down the cardiovascular risk, describing it in great detail, and then treating it. So still, the mainstay of cardiovascular risk management is 100% equal for people who have to undergo cancer treatments or normal people. So it means achieving normal blood pressure, treating hyperlipidemia, smoking cessation, exercise. So it's all in there. Then the second part is what we don't know very well. There's a few randomized trials where patients received cardioprotective drugs, for example, based on increased troponin levels or GLS. And then there is some signals that may actually allow better treatment of cancer, so better cancer survivorship. But the trials are not very powerful and not robust. So well, if you're interested in becoming famous, then maybe you should launch such a trial and show definite answers. And I think everybody's waiting for that, but there's no magic stick. There's a few, some of the orphan drugs and of the, let's say, more exclusive drugs are now coming out for specific diseases. For example, immune checkpoint mediated myocarditis. There's been a trial done with the rheumatoid drug abatacept, which is a T-cell modifier. And that was then given on top of steroids. And that appears to be more powerful. But that, of course, is a kind of a niche indication. But for the cardiotoxic pool of patients at large, it's still the normal cardiovascular drugs.
You remember, cyclooxygenase 2 is involved in carcinogenesis and tumor growth. So colon polyps, I thought about it when you showed that, with Vioxx and Celebrex at the time, you could reduce the growth of colon polyps and beneficially reduce that. Unfortunately, it came a little bit at the cost of more exposure and reduction of prostacyclin in the coronaries. And there was a discussion whether that would increase cardiovascular events.
It's still in use, I think.
I know, for colon polyp prevention. The NSAIDs do that.
Yeah.
And so that is something that's free radicals, whatever the COX-2 is also inflammation.
Yeah. But that is a good example of a drug, I think, that initially, or at least a mechanism that initially was explored in the cardiovascular field,
Exactly.
but then turned out to be efficacious in the field of our friends. And likely there are a lot of course, what we are looking for is the sweet spot, drugs that are beneficial to the cardiovascular system, yet inhibit tumor growth. That's not so easy. But that would be the $6 million drug.
Well, any more questions? I think we have to round it up because that's already an hour and we have to go back to clinics. Is there any more questions from the chat room?
Just one question.
Who is it?
Can I ask?
Yeah, please. Who is it?
This is Shahab Anwar. I have just a quick question. In What to Do Now, you have mentioned awareness as the first point. What are the current approach or the current initiatives that are available to approach that, especially that the topic is really tough on both sides for the cardio-oncology and heart failure as well? Thank you so much, Professor Boer.
I'm not sure.
I'm not good. Is it Shahab who is doing that? We couldn't hear you. Can you speak louder on the micro?
So my question is that in the last slide you mentioned it's about the awareness, like it's very important to approach the awareness of the patients.
Okay.
And I would like to know, are there any approaches that or initiatives that are now running to approach the awareness of the patients as well as the doctors about the tough topic in like cardio-oncology as well as heart failure?
Yeah, now I get it. Yeah, so awareness, I agree, is a somewhat generic term and it's not very concrete. And that is because it is not very concrete. But I would say in the same vein that a heart failure doctor during a consultation is aware of, is there renal dysfunction, is there hypertension, is there chronic pulmonary disease. You should also be aware of signs of malignancies, because as we discussed today, they may be present, and ought to be aware of it. To make it practical, I think the only thing right now we have in our hands is be part of screening programs. And of course, another way that many tumors get detected is that many patients with cardiovascular diseases undergo imaging studies, for example, CAT scanning or MRI scanning. So the very least we should do is always ask the radiologist to have a meticulous look at the coronary arteries, the myocardial muscle, but also into the entire thorax, because there may be something lingering around. I think that is another way.
One patient population where we systematically do that is in the pre-transplant workup.
Yeah.
And there, Andreas, I don't know how, my gut feel, literally, because it could be colon cancer stuff, is that when a little bit more than expected, when we actually do a thorough pre-transplant workup, we detect something. Yeah. And these are patients usually with a 10-year heart failure story.
That's a good one. We should also have a look at.
We should look at that. Actually, that would be, if we just only look at the ones we've screened in the pre-transplant workup and in whom we found some. And I remember some vividly where we actually found some, because they get all routine colonoscopy, CT scans. Then sometimes we see incidentaloma because, because the lymph, and we think that's a pulmonary process, but it could be actually. What you told us today is very much towards what we try to do in integrated cardiology. We look a little bit beyond, put everything together. And that's actually, I got a lot of clinical thoughts from what you were saying today. It was wonderful. Do you have one last question? Because it's really exactly now an hour, and many of us have to go back to work. Well, this is not work, this is fun, right? So I think give a round of applause for Rudolf. Thank you very much.